Hello friends, welcome back to one more episode of video sessions in the STEER team. Today we'll be talking about importance of JVP measurement. What is JVP? JVP is a jugular venous pulse or jugular venous pressure. It is the fluctuations which are generated during a cardiac cycle in the right atrium, which are then reflected backwards into the neck veins, and they are known as jugular venous pulse. Unlike all other pulsations that we normally palpate, jugular venous pulse is observed or inspected. Let us understand how to examine for jugular venous pulse. You make the patient lie down at 45 degrees incline. Make sure that the head is supported. You have to stand on the side of the patient, preferably at the same, your eyes should be at the same level where you are observing. Do not use a measure tape to measure the JVP pulsations, because JVP is the vertical distance between the sternal angle and the highest pulsations seen in the neck vein. So the best way to measure is have two foot rulers. You keep one vertical foot ruler starting from sternal angle and put another one at an angle, at a 90-degree angle at the place of waveform. Thereby you measure the vertical distance of the JVP. The normal JVP is around 4 centimeters when you measure the distance from sternal angle, which is reflected as approximately 9 centimeters from the right atrium. This in turn reflects the central venous pressure of about 6 millimeters of mercury, which is the normal range. When we measure JVP, which is around this measurement, this is considered normal. Whenever the JVP is raised, most of the time it is because of the increase in the right atrial pressure, which could be because of many reasons, unless there is another reason by which there is a SVC obstruction and there is rise in the JVP. Once we are going to measure the JVP, we must know how it looks like. So JVP looks like a double waveform, and it has multiple waves, starting with A, followed by X, C, V and Y. A represents atrial systole, X represents the tricuspid descent, C is tricuspid closure, and V is because of the contraction. The ventricular filling happens, tricuspid valve opens and empties the atrium. That leads to the descent, final descent, that is the Y descent. Now this full AXCVY pattern is repeated with every cardiac cycle. Normally, this is a double waveform, and you see the variation due to respiration, you may see variation due to posture, and you may also have presence of what is known as hepatojugular reflux. That means when there is a gentle pressure given in the right upper quadrant, one will see a slight transient rise in the JVP, which even on sustained pressure will come back to normal. This is known as the hepatojugular reflux. We'll elaborate a little bit on this in a while. Now, whenever the JVP is increased, as we mentioned earlier, we must think about right atrial pressure increase. And the common conditions are congestive heart failure, cor pulmonale, myocardial infarction, and more importantly, for children, iatrogenic fluid overload. Whatever is the reason, if there is increase in the fluid in the system, that will result in raised JVP. Normally, when we take inspiration, there is decrease in the intrathoracic pressure, and so the JVP falls. If instead of falling, the JVP rises, then it is called the paradoxical rise of JVP. Now this we observe in two conditions. One is the cardiac tamponade and more, second one is the constructive pericarditis. If you observe the wave pattern, if the X descent is more significant or dramatic, then you consider constructive pericarditis as more likely. This we are talking on basis of only JVP. Of course, we always use JVP as an additional support for our overall other investigation. If then when there is a hepatomegaly, you must always remember to check the pressure. JVP is not only used for cardiac cases or patients with cardiac conditions, but we must also remember to elicit hepatojugular reflux, as I described earlier, in all patients with hepatomegaly. That means any child who comes with hepatomegaly, one should give sustained pressure on the right hypochondriac region and simultaneously see if there is a transient rise in the JVP. And remember, it has to be a transient rise and not a sustained rise. If there is an absence of hepatojugular reflux, that means there is a likelihood of either constrictive pericarditis or some other conditions where there is a hepatic vein blockage. So friends, JVP we all know is often neglected and more difficult to do examination, but it is part of our clinical armamentarium and we must understand and practice to make the best use of this particular examination finding. Thank you very much for your patient hearing. We meet again next time. Thank you.